Welcome to Friday Focus, March 4th, 2016. I'll talk to you about places where problems can occur in our business, in our practice, and where errors can occur. And we know errors occur and we want to try to avoid them. We put processes in place to try to avoid them. And sometimes we look at what we think is supposed to be done and we just assume this is the only way to do it, therefore that must be what we have to do. And we keep doing it over and over again even though we know it's prone to errors. So I'm going to talk about one place where errors occur, and it's at checkout. And the errors are really of two types. First off, there's the appointment. And number two is the collecting of the money. I've seen charts where the patient had a 6-pack of filler, which is $1,500, and it was written on the treatment sheet, but not on the green discharge sheet, and the person checking them out couldn't really figure out if that was a plan or what, so they let them go home. Patient didn't say anything, and we're out 6 syringes of filler in the patient's face, and we didn't get paid for it. It might be a situation where I say, well, I want to see you back here in 2 weeks to recheck this, in 3 months to redo your Botox, in 2 weeks to recheck your wound. And I'm talking to the patient, and it's kind of hard to write all that, and the medical assistant's in there with me, or the ultrasound tech, or the esthetician. And then we're bringing a third party in to try to figure out what the discussion was, and maybe they can't do it. So we're going to make some fundamental changes. I brought it up at the Shelby Lean meeting last week. This is going to be one particular segment of that we're going to roll out to the whole practice. Okay? Now I've been trying to do this for some time, and there's been a lot of resistance because we resist change. That's natural. Before I get to that, let's just talk about why these errors occur. Let's say, for example, you're working on something, working on a project, and you got your head in it, and you're reading it, and you're thinking about it, and you're trying to develop a plan. And you get interrupted to go see a patient or take care of something. Starting that process back up is enormous. In fact, it's been shown scientifically that it takes 25 times more time to start a thought up again than to continue it. Okay? Same thing with errors. We do something that I think is ridiculous, which we call auditing. So you have somebody that's checking somebody out and there's maybe an error occurs. And if the error occurs and it's not picked up by that person or not avoided by that person by being careful and looking things over, maybe turning back and see if the patient got the filler, the chance of the auditor picking up is pretty slim because now she has 300 charts to look at. And then she's got to figure out whether they get injected or not. I wasn't there on the floor. It was 3 days ago. You can't even actually ask the patient, did they get anything or not? You can't look at the table and see there's empty syringes. So now she's got to try to backtrack to the inventory, and I'll tell you it's the same thing. It's like 25 times longer, okay, to figure out if this event actually occurred. Where if you walk in the room to check somebody out and you see a pile of syringes and some bloody things, you're like, yeah, you got something done. It's not written down. I better figure out what it is. Moreover, the person that, say, did the injections, check the person out. Maybe that makes sense too. I don't know. So when errors occur during that kind of handoff to the person that's not primarily involved, and then trying to do something like auditing to pick up mistakes, I want to get rid of auditing. That is a colossal waste of time. We should do things right the first place. A good example for me might be in surgery. When I'm doing a surgery, if I don't take care of something and there's a problem I got to fix later on, it takes way more time than doing it right the first time. Now certainly surgical problems do occur, but if I can be more diligent in avoiding them, I save myself a lot of times on revisions, which takes a long time. We got to set them up, block time off, a real pain in the butt. Okay, so checkout. We have an action that occurs, right? So it might be a dermatology removing a mole. It might be a new patient consultation. It might be a Botox treatment. It might be an MFT in the leg veins that we're talking to them about doing something else. So we have an action. We have recording the action, so we got to record it somewhere. And then we have to account for it. That's just for the action. And then we have the discussion. And the discussion might be, I want to see you back here in 3 months. It might be that you're all done, you go to as needed. It might be that call us when you have a problem, and otherwise we'll see you in 2 weeks, or maybe we're leaving a drain in for a few more times. So the discussion, it goes on between the doctor and the patient, and usually there's a medical assistant or some or ultrasound tech in the room. And then we bring in a third party, which is the checkout person, to try to put all those things together, create an event where she is taking the money or the insurance or the credit card, scheduling the new appointment, hopefully getting the 2 appointments right. Maybe we want them to do an HRT visit in addition to our next Botox visit, and then getting the patient on the schedule. There's a chance she'll say, well, you want to just give us a call? because it's too complicated, right? And it's going to lower our recurrence rate. So now what we're going to do going forward is we're going to get back to the concept that has been resisted: in-room checkout. In the room. Now sometimes we'll think, well, this is going to slow us down. Only if we think of this in a linear fashion. Linear thinking is that you got to do things in a certain order, okay? So in-room checkout is going to be where you're checking the patient out in the room. You're more likely to see that actions occurred. So if it's not clearly written on the super bill, you can find out. In-room checkout might be the ultrasound technician scheduling the first 4 endovenous laser ablations, because we know if she does not, the chance of the checkout person being able to do it is much lower if she goes to the front desk. Because when you sit on the front desk, that whole discussion and the whole commitment that occurred is now lost, and there's a third party that they can walk away from, and then life just goes on. More errors can occur, and I heard that some of the offices aren't doing the in-room checkout because they don't feel they have enough rooms, or some construction going on. It actually takes longer, okay? It actually slows you down more. Let's say you're doing a mapping, and they're in there for an hour, and you finish your stuff up, you get your photos, now you send them to the front desk, and the patient wants to get the heck out of there. They've been waiting there for an hour, and they just want to leave. Whereas if you went into the room while the mapping was going on, clearly the tech can tell you about how many appointments they're going to need, and you start, booking them. Okay, so you on Wednesdays or Thursdays, let's like 2 o'clock or 4 o'clock, and you start getting that going. That way when a patient is done and they've been measured and photographed, you just give them their appointment card. Okay? What we're doing now is doing this linear, where they got to go through this whole process. They do the consult, we schedule for mapping, mapping's done, we go through the photos, we do the consent, and at the very last, we schedule them for production. Production is going to occur. Do production simultaneous. They're 2 different people, okay? And you have the tech's got the best relationship with the patient. Well, ideally, we had the tech scheduling the first ablations. There might be that they have somebody come in and help them to schedule them. I know at some of the offices, they feel that maybe the scheduler and the tech have some mismatch in their time availability, and the checkout person should be helping out. Then bring them in while you're doing the mapping. But the tech should be responsible to make sure all the mappings get scheduled. Same thing with checking out a Botox filler patient. If you're the MA, you know exactly what got done, the discussions that occurred. You should be the one checking them out, and we're going to make it so that you can check the patient out, collect the money, and so that you can rebook them. Okay, that's going to reduce errors versus them walking to the front desk trying to figure out what the heck got done. Okay, they weren't in the room. There's no evidence that something got done, like seeing empty needles, and they're looking at a chart and trying to piece together what happened. Whereas an error might occur where maybe the PA didn't document her Botox. You know it got done, you realize, I better give her the chart so she fills in the units of Botox. So the in-room checkout is coming. At Shelby, I'm actually going to put barriers at the old checkout. There's going to be boards right in front of there. They're going to be removable for open houses, but there'll be barriers for checkout. Okay, so you just can't go there. It's not going to cost any jobs. In fact, it'll make us more productive, which will make us make better revenue so we can hire more people. And as the business grows, we'll shift people around, but this is not going to cause any checkout person's jobs. It's actually make your job more secure because it'll be more profitable. So in-room checkout is happening. I expect this to occur at all locations. If you're having some problems at your location because of some fundamentals, I can help you work through it. But it will save time because you're going to have less errors. Let's take dermatology in Southgate, which is kind of maybe stressful with the lack of rooms. You already kind of know they're coming back in the year. Instead of sending them in a line at the front desk that makes the waiting room look busier, have the front desk person come back and check them out, or the MA schedule them for a year right now. Take the payment in the room, you already know, or maybe take the payment on check-in. What about patients checking in, and before they get in the room, it's going to be a $10 copay, take it then. I'm not sure what the real solution is because I don't understand how the billing works, but you should figure it out for your own office so you shorten that length of time and they're not standing in line at checkout. Those days are gone. Okay, so we're going to wipe it out entirely here at Shelby. This is where I'm working. I can kind of watch it, but by the end of this quarter, it's gone everywhere. Okay, we have to be prepared for this. We're going to be more efficient. We're going to have less waste. And we're going to copy more efficient models. So in-room checkout is here. We do have to make some adaptations. We might run into some headaches that we'll fix, but this is here to stay. We're going to get a way to check out. There's going to be like an iPad or an iPhone where you can have the patient do the signature, so we're not printing out receipts anymore. We can email it to them. That stuff's ordered. It'll be here in a couple weeks. So start working on getting yourself ready for it. Start practicing with it. That way when we roll it out, you're not like standing there with like a deer at the headlights trying to figure out why we're doing this. We're doing this to shorten the time, make a better customer experience, and to cut down on errors. Thank you very much.